Okay, Dr. Ganguly, shall we get started?
Sure. Right.
Okay. Good evening, everyone, on the Zoom platform and the ones listening in on YouTube. Welcome to this month's Journal Club. The presenter for this month's Journal Club is going to be Dr. Debottam Ganguly. And it's an interesting article that we have chosen for this month's JC. It's a one that is from India. It was published in Neurocritical Care last month, November, and it's on mobilization in pediatric neurocritical care. Quite an exciting article. Over to you, Dr. Ganguly.
Thank you, sir. Uh, as a intensive in the mainly in the adult ICU, even we are doing neurocritical care in daily basis, but we are not that much keenly attached with the rehab of these patients. So today's journal club is quite interesting, both because of pediatric population where we talk about the pediatric population, how the things goes over there, and as well as we discuss about the different rehabilitation techniques and therapies that people usually under during a neurocritical patient and can undergo.
Your
So in
voice
view
is
of
not.
that, we
Sorry, Dr. Ganguly, your voice is not clear.
okay, sir, actually, is it better, sir? Hello.
Yeah, it is better now. It is better.
Actually, sir, I'm on duty. There's some sound of ventilator over there. It may be disturbing for.
No problems at all. Go ahead.
Uh, so rehabilitation in neurocritical care actually have two aspects today. Number one, prior to going to the article, choice of article, just I want to I have make few slides just to discuss some thing and some points and topics that will help us to easy understand of the article proper. So for that, I mean the two things are important. What is the difference between rehabilitation in neurocritically ill adult patient and pediatric patient, and the some other thing also like what the type of the therapy we can offer to the this patient. So advance in the critical care medicine have resulted in reduction mortality but increased morbidity in the survivor. And this actually true for both in pediatric population as well as the adult population. And also know that goal of rehabilitation includes prevention of complication associated with immobilization and evolving tone, and evaluation and treatment of functional deficit, along with implementation of adaptive strategies with the goal of maximum recovery. So rehabilitation for child is little tricky because few things are and the gray areas are there. Number one, there is no proper guideline for rehabilitation of child, which is present in case of adult. So this is the thing, and rehabilitation associated with multimodal approach and comprehensive interdisciplinary rehabilitation in the critical care adult care is there is present in guideline is there for adult patient, but not that popular guideline is there for children or pediatric age group. Following critical illness, 82% of the children experience a significant functional decline in at least one development domain. Now, the thing is that the child in a normal child, there is a development is a dynamic process. So there is a maturity of mental maturity as well as the physical maturity is there, particularly when the patient became critically ill, like neurocritically ill patient, the dynamic process disturbs, and that makes much more complex for rehabilitation for these child. Family-centered service are widely accepted as best practice. Family involvement is very much required for the rehabilitation for this pediatrics age group. Not only family, the involvement of the community also important for that purpose. So the revolution process actually our target to start from the from as early as possible in the ICU level, then inpatient or acute care level, then school, home, and community level, and that will be ongoing a process throughout until unless he reach the maximum recovery from his trauma or issues. Now, post-intensive care syndrome. It is a common topic. Same applies for children as well as the adult. Post-intensive care syndrome to describe a new and persistent decline in the physical, cognitive, and mental health functioning that follow an ICU stay and for which other causes such as traumatic brain injury or cerebrovascular accident have been excluded. The term PICSF is applied to the close family member of ICU patient who experience subsequent adverse mental health outcome. That can be anxiety, that can be depression, all this, even family. So the post-intensive care syndrome is not applicable only to the patient, but also their family members also. And in case of child, that much more impactful for for pediatric age group. So impairment allowing an ICU stay in pediatric patient deserves special attention as this occurs within already dynamic state of childhood development, as I told earlier. Additionally, because even healthy children are inherently dependent upon the support of their parents and other caregivers, a child's recovery from PICU stay inevitably impacts the entire family unit. Now, the actual trial or article have mentioned pediatric cerebral performance category scale multiple times, PCPC scale. So I just want to elaborate the scale prior to digging into the topic. So PCPC score or pediatric cerebral performance category scale has six score 1 to 6. Category 1 is normal, 2 mild disability, 3 moderate disability, 4 severe, 5th coma or vegetative state, and 6 is the death. So normal means age appropriate level functioning in preschool age children, appropriate development in school age children, and attendance in regular classes. In case of score 2, they can interact at an age appropriate level, but they are associated with minor neurologic disease that is controlled and does not interfere with daily activity, like a seizure disorder. In preschool age children, possibility minor developmental delay, but within more than 75% of all daily living developmental milestone is above 10 percentile. What is in school age children, attendance is regular school, but maybe a grade that is not appropriate for the age. It can see in score 2 or mild disability children. Whereas code 3 is moderate disability, below age appropriate functioning, neurologic disease that is not controlled and severely limit activities. In school age children, most daily living developmental milestones are below the 10th percentile. In school age children, they can do daily activity but attend special classes because of cognitive difficulties or learning deficit. Score 4, severe disability in preschool children, and their milestone is below the 10th percentile and excessive dependence on other for daily activity. And in school age children, there is possibility of severe impairment that prevent school attendance and dependence on other for daily. In school age children, preschool children and school children, possible there is abnormal motor movement, including non-purposeful decorticate or cerebral response to pain. This can be seen. Coma, as I told earlier, there is totally awareness of the environment, and last option, the six is the death. Now, rehabilitation therapies. There is a multiple way to rehabilitate, and physiotherapy, one of the most common and mostly used in everywhere, is physiotherapy. So, physiotherapy or physical therapy helps to perform physical movements. It can be part of a generalized pain management plan or a specific treatment for an injury or health condition. People usually need physical therapy to manage symptoms of health condition like pain and stiffness in a specific body part. improve flexibility, strength and balance and coordination. Physical therapy or physiotherapy may include stretching, strength training, hot and cold therapy, hydrotherapy, all these things. Now, occupational therapy. Occupational therapy will help to improve ability to perform tasks like that help in our day-to-day activity. It helps patient to get dressed, take medicine, uh, or driving or use a computer like this. So physiotherapy and occupational therapy, those sounded similar, but the purpose is different. Physiotherapy help to increase the strength or help in the increase the flexibility, improvement of the tone, whereas occupational therapy is implementation of that power to his real life or to perform day-to-day activities. Occupational therapists help to increase physical strength and coordination of the individual through the exercise. Learning to use new equipment like prosthetic limb or wheelchair is one of the most example of the occupational therapy. Now, speech and swallow therapy. Speech and language pathologists work closely with the children and adults who have various level of speech, language, and communication problem, and with those who have swallowing, drinking, or eating difficulties. They also help in the articulation of the word, improvement of fluency, voice control, modulation, comprehension and expression of language, ability to swallow, and reduce the risk of aspiration. So these all the things comes under the rehabilitation, which is a multidisciplinary, multi-team approach, thing. Now there is a term block randomization. I have put this slide because the original article have performed this block randomization. So what is that block randomization? When done, usually done when the sample recruitment occur during the study. I mean, all sample was not present from beginning of the study. It is recruited during the study. As the study grow on, the recruitment is going on. But the researchers want to maintain same in number of the subject both in intervention group and the control group. So they have divided total sample into block and thereafter the divided and randomization take place. Another topic is violin plot. So this is also present in the article. So I have just wanted to explain it because it is not commonly used statistical thing. So violin plot is a hybrid model of statistical graphic for comparing probability distribution. So it is used to compare distribution across the different categories or groups. So it look like a violin, that's why it is called violin plot. The outer layer of the violin plot indicates kernel density estimation, display the density of data at the different values. The wider section suggests the high density, that is more data points, whereas narrow section indicates lower density or fewer data points. Symmetrical violin plot means it's mirrored to the density estimation on the either side of its axis. Now, inside the violin, there is a box plot which indicates additional value of the data distribution. The box plot actually has three parts. The middle portion of the box plot is the median, and the lower limit or lower quartile, and the third quartile, that is the upper quartile. The, there is a whisker that indicates the variable, the outside of the upper and lower quartile. That indicates the outlier. So block spot shows the summary of the statistic like median or the quartile, whereas the total violin plot actually display the full distribution of the data. For better understand, I have given put some example. Like this is a example that is some patient underwent surgery and the researcher want to know the recovery time for different age group. Like as I plotted over here, the young adults, middle aged, and seniors. There is three separated age group. If for young adults, suppose recovery time is 5 days from surgery, some for 4 days, some for 6 days. For the middle age, 7, 8, or 17, like that one, there's a formation, I mean, there is a grouping. And if we plot a violin plot, and then we can divide it into young adults, middle age, and seniors. Like young adults here, we can say that the recovery time, overall recovery time is around 3 to 8 to 9 days. Whereas for the most patient, it is around 5 to 6 days. So like that, middle-aged and seniors are divided similar way. So violin plot has been used for our study purpose. That's why I have put this slide. Now this is another slide and the last slide prior to our original article, discussing our original article. It is published by Think et al. In the year 2019 in the Journal of Pediatric Critical Care. And this has put because the mother article, actually our author went through this and makes this article as their mother article, and there's some and basis of this article the further trial, the RCT has been planned. So this was the randomized control trial taken in the three tertiary care PICU in the United States. 58 children between age 3 to 17 years with new traumatic or non-traumatic brain insult and expected ICU admission more than 48 hours are the population. So intervention was early protocolized within 72 hours, protocolized rehabilitation within 72 hours of the ICU admission or usual care. Outcomes are totally different of our study than this. The primary outcome for them was consultation timing, treatment type, frequency of deferral, and safety events. And when we start give consulting, we consult with rehab people and what lead to defer it. These things they have documented. But secondary outcome also these were there, that's included the family and patient functional and quality of life outcome at the end of 6 months. So in this study, they have concluded that a protocol for early personalized rehabilitation in pediatric neurocritical care patient could safely implemented and lead more ICU-based treatment sessions and accelerating the temporal profile and changing composition of intervention versus usual care. Now come to our today's topic, today's study, that is early protocolized rehabilitation versus usual care in improving functional outcomes in pediatric neurocritical patients. So it is a randomized control trial. Researcher was from India, Aman Elwagi, Pratik Kumar Panda, Amit Kumar Tyagi et al. In the All India Institute of Medical Science, Rishikesh, Uttarakhand. The study was published online on 4th of September of this year and printed copy has been published last week only. It is published in the official journal of Neurocritical Care Society. So in introduction, the authors has disclosed the survivor of the critical illness often experience long-term disability, higher rate of readmission, and poor health outcome. So these children are very prone to have adverse physical, cognitive, and psychological effect even after recovery from the critical illness. So as I told earlier, it is the post-intensive care syndrome in pediatric population. Children with primary neurological condition have more risk for post-intensive care pediatric syndrome. In adult patient, as I told earlier, there is a protocolized intervention have shown that multiple benefits, including reduced incidence of delirium, shorter hospital stay, and improved emotional health without compromising safety. So there is a very limited study among pediatric age group, particularly in India. So in view of that, they want to do the study in pediatric age group and in India. So this is the introduction part, and they have why they are doing the study, and that is explained in this portion. Now, in objective, though, they want to evaluate the benefit of early protocolized rehabilitation program compared to the standard care in the improving functional outcome for pediatric neurocritical care patients in the PICU. Comparison of other functional domains such as adaptive function, cognition, motor and language ability, behavior, sleep, quality of life, and family functioning, along with the assessment of the adverse effect, mortality, and implementation related challenges in resource limited settings. So they are also look for all these things, whether other domain, other adaptive function, okay or not, whether there is any changes in that or not. Along with that, there is any adverse effect, mortality, or in any challenges in the resource limited setting for the implementing of rehabilitation. What is the current study in India? They want to research in this article, in this thing,
Devotam, can we
research.
pause for a second?
Sure, sir.
Yeah. So just a few things. Whenever we look at an article, when we read the title itself, the first question you would ask is this title relevant? Is this something that I would want to look into, I would want to practice, etc., or I've been thinking about. So this title is although it's in pediatric neurocritical care, mobilization in intensive care in general is picking up pace, and we are talking about it more and more. And in neurocritical care, it's even more relevant. So this is a relevant title. Although it's pediatric, it's a relevant subject. Number one. Number two, when we look at the initial research question, we put it in the PICO framework, right?
Yes,
PICO.
sir.
So the population is pediatric critical care, neurocritical care patients. Intervention is the early rehabilitation program. Control is the usual care, and the outcomes is the functional outcomes at 6 months. The next question that you would ask is, are these outcomes relevant? Is this the kind of outcome that I would be looking for whenever I do an intervention like this? Have they tested an appropriate outcome, or did they ask for an appropriate outcome from their study? And again, I would say the answer is yes. Yeah, they did look at an appropriate outcome. So PICO framework is one that we should talk about whenever we look at a research question. And we should also ask a question whether this is relevant for us. This is an Indian study, so clearly this is, the population is also our population, and it's a relevant question, and it's kind of a hot topic, mobilization. So that's why, we were interested in this particular trial. Right, go ahead.
So it is a single blind, parallel design, randomized control trial. Its duration is December 2021 to June 2023. As I told earlier, it is in All India Institute of Medical Science, Rishikesh in India. So it is for our population, our people, it is very much relevant to the topic. And the study population is pediatric neurocritically ill patient aged 1 to 18 years with pre-morbid PCPC score, that's pediatric cerebral performance category score 1 or 2 within 2 weeks of illness onset. So if we go through the inclusion of the criteria of the study, it is now to suppose a patient present with a PCPC score 3 or 4, but it was 1 or 2 within 2 weeks of illness, and then they are included. These patients are included in the study, and that could be primarily neurological problem or systemic illness that associated with metabolic or septic hypertensive encephalopathy, and along with some hypoxic encephalopathy is there. So this is the study population for this research. And sample size, they have calculated the required sample size was around 55 patients per arm, intervention arm, and the controller 55 plus 55, 110. So what are the exclusion criteria? The children with an expected survival of less than 24 hours, pediatric sequential organ failure assessment score more than 20, children with absent brainstem reflexes, that is PC score of 6, or death, children requiring mechanical ventilation only during perioperative period, or effect of under the effect of sedative or anesthetics for the diagnostic procedures. Children with rapidly progressive neurodegenerative disease without curative treatment, and children who had already received mechanical ventilation for more than 72 hours before presenting to the institute. Hemodynamic instability, uncontrolled rise intracranial pressure, uncontrolled status epilepticus lasting for initial 72 hours of mechanical ventilation. These all are excluded from study. So randomization, as I told earlier, a computer-generated random number list with variable block randomization was used to maintain equal numbers of participants in both arms. Each random number was placed in a opaque sealed envelope, which was only opened at the time of participant allotment. Allocation was managed by a separate investigator who enrolled participants and assigned them to either the usual care or the EPR arm. Now, intervention. Therapies were initiated as early as possible, that is, within 72 hours, particularly for medically ventilated patient, and the therapy continued for 24 weeks from the date of enrollment or until the child reached pre-morbid baseline status, whichever is earlier. Physiotherapy or physical therapy, occupational therapy, speech and language therapy for each participant in the intervention group in a protocol-driven specific manner it was performed. So everything I have discussed regarding what is physical therapy, occupational therapy. Initially, the session were held daily for 1 week, followed by thrice a week for 1 month, and then monthly after discharge. Now, this session was at least for 30 minutes, and when it is done twice in a day. The 30 minutes twice a day for 1 week, then thrice in a week for 1 month, and then monthly after discharge. But each session contains of 30 minutes. Supplemented audio-visual teleconsultation was performed for at least 15 minute duration every week for a particular patient. This is after discharge when patient is home. Then every week there is a 15 minutes duration audio-visual teleconsultation was there. Now, control group physiotherapy session was typically initiated during the recovery stage, and these are basic and minimum physiotherapy have been implemented. Occupational therapy and speech language therapy session was started only when the child was hemodynamically stable and was on full oral or nasogastric feed. Occupational therapy or speech language therapy session were minimal during the inpatient stage, consistent with usual clinical practice. There were no regular tele follow-up, and compliance with the advice physiotherapist, occupational therapist, or SLT was accessed only during the follow-up outpatient visit. No, not like that audio-visual part weekly, the thing was not there in case of control groups. During the study, one patient with stage 3 tubercular meningitis experienced disease progression and died during hospitalization. This mortality was not causally related to the EPR and was primarily due to the progression of the primary illness. Similarly, there were two mortalities in the usual care group with no significant difference in the mortality rate between two groups. So outcome measures. The outcome measures may be in short term or the long term. Short term at either discharge or death, or long term measure at 12 weeks and at 24 weeks post enrollment. So outcome measures were done by pediatric neurologist and developmental pediatrician. For statistical analysis, they have used SPSS version 29, and there was 10 efficiency outcome measures to account for those multiple comparisons. Bonofini correction was used and instead of the desired confidence confidence level for statistical significance at 0.005. But for comparison of other variables such as baseline socio-demographic variables in both groups, a 210 p-value of 0.05 as statistically significant was decided to use. Now, these are the variables, these are the other functional status they have chosen, like PCPC score for overall functional status, FSS score, that is functional status scale, that also include the functional status of the pediatric age group. They have chosen whose upper value is 6 to 30 and higher score denote the core functional outcome. VABS 3, that is Vinland Adapted Behavior Scale, third edition for the adaptive person. It is 20 to 140. The range is 20 to 140. High score is better score. Mally's Intelligence Scale for Indian children for IQ, that is the cognitive function. The score 1 to 100. High IQ is better. GMFM 88, that is gross motor function 88. The scale was used for gross motor function. The 0 to 234 is the limit. Higher is better in this case. CBCL, that is child behavior checklist for behavioral comorbidity. Score is 0 to 198 for 1.5 years child to 5 years and 0 to 226 up to 18 years. High score means the problem is there. The CSHQ scale, that is Child Sleep Habit Questionnaire, the sleep problem to detect the sleep problem, its score is 33 to 39. Higher score indicates sleep disturbance or sleep problems. CELF score, that is Child Evaluation of Language Fundamentals for the language detection of the language problem, the score is 0 to 100. Similarly, high score detects mood problem. PACE QL, that is quality of life, that is 0 to 100. High score is means good quality of life. And family last is family assessment device composite score for the family functional outcome 1 to 4. Here high score means more problems.
So can we pause here for a second?
Sure, sir.
Yeah. So essentially, they have randomized the neurocritical care children into two groups. One group received protocolized rehabilitation, physical therapy, occupational therapy, and swallow therapy, and the other group received usual care, right?
That's it.
And their primary outcome. So we always divide the outcomes into primary and secondary outcomes. The previous slide, if you go, their primary outcome was CPC, that's pediatric cerebral performance category or cerebral performance scale.
CPC
Yeah,
score.
pediatric CPC score was the primary outcome. And you already mentioned the pediatric CPC 1 and 2. 1 indicates normalcy and 2 indicates mild impairment. So if the child recovers from the illness, you want the child either to be normal in CPC 1 or in CPC 2 category. That's kind of an ideal result. So by giving this physical therapy, how many children achieve the ideal result when compared to the usual care is the question they wanted to ask. And they had a number of secondary outcomes. So whenever you set out to do a trial, it's the primary outcome that you calculate the number of individuals for. You already mentioned using the Fink study. They calculated the number of individuals needed for each group, the sample size. The secondary outcome is not used to it's only for the primary outcome you calculate the sample size. There are a number of secondary outcomes like in this table. When you use so many secondary outcomes, and you end up making multiple comparisons. So for FSS one comparison, WABS 3 one comparison, MISIC one comparison. So you end up doing multiple comparisons. So if you do multiple comparisons, the likelihood of you finding a difference increases. Falsely, you might find a difference. So what you need to do is you need to have the Bonferroni correction that you mentioned in the previous slide. The number of comparisons, the p-value of 0.05 divided by the number of comparisons. So you're doing 10 comparisons. So the p-value is 0.005. So the p-value becomes much more stricter and stringent when you make multiple comparisons, and that's the Bonferroni correction. Yeah, go ahead.
So ultimately, the number of pediatric neurocritical patients screened was 268, but 72 children was excluded from the exclusion criteria. So ultimately, 196 children were randomized. So they have divided it into GCS more than 8 and GCS less than 8 as block randomization. So they are divided into them into two groups. I mean EPR 59 each group, and EPR usual care is 59. So as in GCS less than 8, they is also divided into EPR 39 group for GCS less than 8, and usual care group also 39. So ultimately, the usual care arm total 98. So as the EPR arm is 98, and three lost follow-up, two mortality, completed 24 weeks with the number of ultimate number of pediatric children was 93. Whereas in EPR arm, two lost the follow-up, one mortality, and completed 24 weeks research with 95 of population size. Now, this is the demographic parameters they have monitored, and from this chart, we can say this mostly the population from lower socioeconomic status, uh, 87 and 11 in both group equally distributed almost, and mainly from the rural area. And also we can see that the mainly the etiology of admission or the study for mainly from a neurological basis 127, whereas the respiratory is 25 and tropical infection is 18. But the distribution is equal to the both intervention arm as well as the control arm. Among nervous system infection and nervous system disorder, neuro infection is the most common. 34 for intervention arm, 33 for uh, control group. Now results. So at 24 weeks, the proportion of the
Sorry,
patient
can you go
without.
back to table one? Yeah, can you stop here? So what is different here is the table one is basically the demographics table. We don't generally put p-values in this table because these children were randomized clearly to one group or the other. The interesting
Mhm.
thing in this is they've given p-values. We don't necessarily need to do it, and generally journals don't want p-values in table one, but on this occasion they have allowed p-values.
Right, sir. Now, result at 24 weeks, the proportion of the patient without significant disability, that is PCPC score 1 or 2, was 99% in the intervention arm and 85.7% in the control arm, which was a statistically significant difference. Irrespective of the initial GCS less than 8 or more than 8, the proportion of the patient with no or mild disability, that is PCPC score 1 or 2 at 24 weeks, was more in the intervention arm in compared to the control arm and favoring the early protocolized rehabilitation group. PCPC score, that is they have shown through the violet plot, and the violet plot showing the maximum distribution along with PCPC score 2 and 1 in the intervention arm, but the distribution along the PCPC score 2, 1 and 3 in the control arm. So PCPC score, it was found the average PCPC score was better in the early protocolized rehabilitation group as compared to the control group at 12 weeks, but not other time like 4 weeks or 24 weeks. So they also analyze the change in the PCSPC score from the clinical nadir at 4 weeks to 24 weeks. This showed that there is a significant greater improvement in the EPR group compared to the control group, with the mean change of minus 2.02 versus minus 3.12, with p-value less than 0.001.
Can I ask you a question?
Sure.
Um, do you think this is appropriate to calculate a mean of the PCPC score? What is your background? Are you an anesthetist or
Anesthesia.
you are an anesthetist? Yeah. So let me just think. So there is ASA grading for anesthesiologists, isn't it?
Yes, sir.
Yeah. So can you say that the patient's ASA grade is 2.2?
No, sir.
No, it can only be 1, 2, 3, 4, 5. I think it's up to 5, right? Yeah. So 1, 2, 3, 4 are the grades that you kind of use, and that's called an ordinal scale. And CPC, you put it up quite well in the first slide itself that it's an ordinal scale from 1 to 6, 1 being a normal child and 6 being a dead child or dead. 6 is death. You cannot have a 1.5 CPC or 2.5 CPC, 3.5 CPC. So when it comes to ordinal, when you use the ordinal data, you don't generally calculate the average or the mean of the data. You just use it as an ordinal data. So they have clearly dichotomized, which means they have separated 1 and 2, 3, 4, 5, and 6, and they have compared the two. The proportions are really good, like 99% versus 85%. They showed approximately a 14% difference in the outcome. So there was, I don't see a need why you should actually calculate the ASA of all your patients and come up with a mean ASA of my patient's mean ASA was 3.1. Makes absolutely no sense. But they have done it. I just thought I'll mention it here.
Right. 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 So this is a secondary outcome chart, and they have taken all the 10 outcome measures, and they have do the studies and intervention and control, and we will come to next slide regarding the violin plot of each and every measurement. And it shows that sleep quality, family function, pediatric quality of life, adaptive functioning from adaptive scale, Vinland adaptive scale 3 have shown statistically significant improvement in the EPR group. The intervention group demonstrate numerically lower mean FSS score, score at 24 weeks, so as the IQ scoring, language function, GMFM, that is gross motor function, 88 score, but these were not statistically significant. So all are show some amount of improvement, some are statistically significant, some are not significant. Total CBCL score, that is total CBCL score, that is child behavior checklist score, was significantly lower in the intervention group. This suggests that intervention group had significantly lower behavioral problem as compared to the control group. In the CBCL, the interlining problem refers to the difficulty directed inwards, that is anxiety, depression, somatic complaint, and withdrawal, reflecting emotional distress or self-focused issues. Whereas externalizing problems involve outward directed behaviors such as aggression, hyperactivity, and rule breaking, reflecting difficulties in the regulating behavior and interaction with others. Together, these domains provide insight into child's emotional and behavioral functioning. So they have, in comparison, they have taken both CBCL intelligence score, also the external score. Both show some benefit if we start each PR group. Now, in conclusion, In conclusion, the authors conclude that early physical rehabilitation in the pediatric neurocritical care patient not only is safe and feasible, but also has potential to significantly improve functional status, adaptive function, cognition, motor function, behavior, sleep patterns, language abilities, quality of life, and family function at 24 weeks post-intervention compared to the usual care. Now, strength, what through the study, after reading the article, what I think the strength of this study is the sample size. Number one. Number two, it is an Indian-based study that also help us for guiding our treatment, patient or treatment, and they have included multiple scale to overcome the limitation of using the single scale. And limitation, it is a single center trial, single blinded study. The rehabilitation in the control group may not be adequate, and the validation of the protocol. They have put the protocol, the early protocolized rehabilitation. They have attach the protocol in the supplement, but the validation of the protocol, I don't know. I mean, I can't find any data regarding that or information regarding that. And what I have doubt that grade of primary disease severity they have not mentioned throughout the study. I mean, the NHS score may be different in two patients, so outcome can be differ for that primary disease also. And this is my personal what after reading the study, I have some question regarding this actually, sir. And they have also read that presence of rise intracranial pressure by clinical, they have measured the clinical parameters only, such as tonic posturing, presence of papilloedema, Cushing trial, and isocoria without any advanced method. That's also.
Thanks, Dr. Ganguly, for that very nice presentation. Quite an interesting study, and they have proved clearly that being even in a government hospital, providing early rehabilitation using a team-based approach is feasible and it is safe, even in children in neurocritical care, and they've shown a clear difference in the outcomes. I mean, you can argue that if they had waited for, instead of 24 weeks, if they had waited for a full year, they might not have found a difference between the two groups, etc. So there can be lots of arguments. And you mentioned that the protocol is not validated. That's a very good point. But then whatever the protocol they had formed, they were able to show the difference. A simple protocol daily for a week, and then was it like twice a week for a week or something? You
For
mentioned, I think there was a slide on
thrice a week, sir. Then thrice a week and then monthly
and then oh yeah,
medication
once a week with video call facility.
video
And these are
conference.
these are children from poor socioeconomic background and from the villages. And that's, I think, that is the power of this study. A government setup, number one. Limited resources, number two. Whatever they had, they put it up together, and they provided rehabilitation. And children from poor socioeconomic background, from the rural setting, if they were able to show this difference for this kind of children from this kind of setup, then clearly this will work if you have a proper, real protocolized rehabilitation. And I think this can also be, and I don't think we can straight away start practicing for adults, but this needs to be tested in the adult neurocritical care population as well, because currently mobilization happens, but not in a protocolized manner, like they mention, right?
Usual care. But sir, I mean, what about the primary disease? What I have doubt that the grading there, they grade many ways for secondary measures. But what about the primary disease? The grade of primary disease also may influence the outcome actually, and
Absolutely.
they did not compare that too.
Absolutely. So you're absolutely right. So the two points that you raised are quite valid and very good. So I think I answered the validity question. The second one, the primary disease does affect the ultimate outcome. They were very clear in their question in that irrespective of whether the primary disease is neurological or a non-neurological disease causing a neurological problem, primary is neurological or not, as long as the child had a neurological problem, they included the child in this study. So clearly, the initial, for example, if it's scrub typhus, you provide very good supportive care and give antibiotics, then the likelihood of the child recovering is pretty good as opposed to a severe traumatic brain injury. You are absolutely right. Yes. But that's why, they have, although they have included all these children, they've randomized them into two groups. And in the first, I think, third slide itself, you talked about block randomization. Block randomization is basically in case if you have to terminate the trial early. You will have equal number of participants in both the groups if you do block randomization. And the other beauty of block randomization is you will have all these different illnesses equally
Validation block
distributed across,
comparison.
yeah, equally distributed across both the groups. And you randomize them. So yeah, you are analyzing the results after randomization, so it's perfectly fine. Any other questions from anybody else? There are about 5 participants. Okay. I think so. The only thing is that I wanted to add was the ones that I talked about. So every question should be put in a PICO framework. It's
Yeah,
very
exactly.
important.
Yeah, yeah,
Yeah,
yeah.
and
I should mention.
you have to separate the outcomes very clearly into primary and secondary. The sample size calculation is based only on the primary outcome, and the sample size calculation does not is not applicable to the secondary outcome. So even if you find if you find a statistically significant difference among the secondary outcomes, that is only hypothesis generating, which means that's just another research question, and you cannot use that to change you cannot say that it is significant and it changes your practice. That is not the way to interpret. And if you do multiple comparisons, you do Bonferroni, your p-value goes really down. Like in this case, it was 0.005, so it's really down. And when you have ordinal scales, it makes absolutely no sense to calculate a mean or an average. I gave an example, ASA category. It is perfectly fine to classify them to two groups, ASA 1, 2, ASA 3, 4, 5, and I'm going to compare the two groups, and that's what they have done. The PCPC 1, 2 versus 3, 4, 5. And I think that itself is a very good statistical analysis. There was no need to come up with all those mean violin plots, but it's an interesting concept, the violin plot. You explained it beautifully at the beginning itself, a new thing for people to learn. Thank you for that. And those are the points that I wanted to make as well. If there are no questions from anybody, shall we close the session? Yeah, I think we will. Thank you, Dr. Ganguly, for that
Thank you.
wonderful presentation. Thanks very much.
Thanks. Thanks. Thanks, sir. Good night,
Thank,
sir.
thank you. Good night.